What's up YouTube? I'm David Warren and welcome back to this week's video. Today we are talking about my life in CRNA school clinicals so far. I'm about 2 weeks in and I want to share with you what I've learned, what I've done, and how things have gone. I want to take you through the past 2 weeks. You can probably tell by the location here from my other videos, I'm in a different place. I'm in Henderson, Nevada on my first clinical rotation, and I want to share with you what it's been like. If you're new here, consider subscribing. My channel is all about being a nurse practitioner and being a CRNA student. If that's of interest to you, smash that subscribe button. Before we jump into the content, I want to tell you about a promotion going on by LECTURIO. So LECTURIO is an online-based learning platform, and they are currently running a promotion for the next generation NCLEX test. As of April 1st, the NCLEX test is the new and updated next generation test. It focuses more on clinical application, and there's some new testing styles that they are incorporating. So if you're a nursing student, I'm going to drop a link below. Click on that. It will take you to LECTURIO's website. They're offering a free 30-question test that will simulate the next generation NCLEX test. So you can gauge your readiness and you can see how you would do on an NCLEX next generation test. Again, it's a free 30-question assessment. I'll drop the link below. Go ahead and check that out if you're a nursing student. If not, we're going to jump right into the content for today. So I'm going to take you through what CRNA school clinicals have been like. So I found out back in January that I'm in Henderson, Nevada, starting around April 1st. I think my first day was like April 3rd, all the way till the end of June. So I'm here for 3 months, and I'm going to take you through what it's been like. And so when I wake up in the mornings, I usually get up around 5:30, 5:45, and I'm usually out the door by 6, maybe 6:15 at the latest. I live about 15 to 20 minutes away from the hospital. I'll get to the hospital and check in and use my badge to get a set of scrubs. I'll get changed out in the lounge area, like the men's lounge. They're separate. If you're not familiar with the OR, I'm like talking through this like everybody works in the OR. You probably don't work in the OR if you're watching this, or maybe you do. But anyway, there's a separate locker room for men and women, and you have to change into hospital issued OR scrubs if you're in the OR. Now there are some hospitals where you don't have to like dress out like that. You can bring your own scrubs, but most places make you change into OR scrubs. So go to the lounge, get changed in the OR scrub. I will take a look at the track board and find my cases for that day, what CRNA I'm assigned with, and then I'll go to the room, and when I get to the room, depending on whatever case it is, I'll get things prepped for that particular case. So for the past 2 weeks, I've been in general surgery cases doing robots. So things like hysterectomies, cholecystectomies, colectomies, appendectomies, really anything general surgery. And so I will get all of my stuff set up in the OR for that day. And so in anesthesia I use the mnemonic SAMTIDE to get everything set up for that particular case. There are plenty of other like mnemonics out there that will help you get set up for a general anesthetic, but SAMTIDE, SAMMTIDE. So we have suction for S, airway equipment for A, and so that means getting your direct laryngoscopy, either a Mack or a Miller blade, getting your airway set up, getting an ET tube, checking the cuff, getting an oral airway, a tongue blade. Get all those things laid out so you like know your airway stuff is ready. And then you always want to have some backup plans. And so that looks like knowing where the LMAs are, knowing where the bougies are, knowing where the glide scope is, knowing where extra blades are. Like if you try a Mac 3 and you can't see anything, maybe you switch to a Mac 4, or maybe you switch to a Miller 2. Knowing where all your backup equipment is super pertinent, especially when it comes to airway. As a student, it's nice to know where all those things are, because it's good to try those different techniques. Even if you don't need them, it's good to like try a bougie one time, or it's good to switch up blades. So it's good to know where your backup equipment is. All of that to say, that's for airway. So suction, airway, machine. For the first M, you want to make sure your machine is checked and on, your vaporizers are full, your oxygen tanks are on and available, the hose from like the OR ceiling is plugged into the back, and you've got adequate pressures. You can do a high pressure test to make sure there's no leaks in the breathing circuit. And then the next M is monitors. You want to make sure you have your blood pressure cuff, your pulse oximetry, EKG leads, and temperature, either esophageal temp or some way to check a temperature. And then T is tape. You want to make sure you have tape for the eyes. So that's a little pertinent thing that I didn't know before I got into anesthesia school is after you're intubated, we do tape your eyes shut. So one of the most common things that happens in surgery, anesthesia related, is a corneal abrasion if you don't tape the eyes, because the eyes can just flop open and things are moving around all up near the head and can cause a corneal abrasion. So needless to say, after we push propofol or after we push whatever induction agent we're using, we tape your eyes so you don't have a corneal abrasion. And then you want, the eye is IVs, so you need to make sure, this is more like in pre-op, but make sure the patient has an adequately functioning IV. And then you also want 2 IV poles. So you'll have 2 IV poles sitting next to your bed, and that's to hang the surgical drapes. So after the scrub tech will prep the patient, they'll send the drape up to you, you'll take some clips and clip the drapes on, so the drape's up by the patient. And then, let's see, that was ID, so SAMMTID are your drugs, and so that's really whatever drugs you're going to be using for that particular patient. And so most often, most commonly, really the only thing that I have used so far for induction has been propofol. And so propofol dosing is 1 to 2 milligrams per kilogram. It's supposed to be of lean body weight, but that's not entirely accurate. We use total body weight in anesthesia, at least where I'm doing clinicals right now. Textbook wise, you're supposed to use lean body weight. It's either lean body weight or ideal body weight. Correct me if I'm wrong. If you know if it's lean or ideal body weight, comment below. I'm pretty sure it's lean body weight, but it might be ideal. I'm highly certain it's lean body weight induction dose of propofol. If you know, comment below, let me know. 1 to 2 milligrams per kilogram of lean body weight. However, like I said, most people use total body weight. So if you have somebody that's like 100 kilos, they're definitely getting 200 of propofol, if not a little more. And then obviously depending on their drug use history, if they smoke marijuana, they're a chronic alcohol user, you're going to want to increase that dosage because those GABA receptors have been built up a little bit by their chronic use of substances. So that's how you dose the medications. So we use propofol. Well, before that, let me back up a little bit. We'll use fentanyl and lidocaine. So fentanyl to block the sympathetic response to laryngoscopy, meaning that whenever we do the intubation, we put the laryngoscope in, pass the tube through the cords. That's the most stimulating part of a surgical procedure. It's not the cut that the surgeon does on whatever part of your body. It's definitely intubation. So those of you who have seen intubations or do intubations and you don't routinely give fentanyl or esmolol or something to blunt that sympathetic response, you will get transient tachycardia after, hypertension and tachycardia usually after induction, probably followed by lowering of the blood pressure and maybe some like post-induction hypotension. But there initially, usually you're going to get that sympathetic response, and that is just because the airway is so heavily innervated that whenever you start manipulating it, it's going to go crazy and you're going to get that sympathetic response. So all that said, we give fentanyl 1 per kilo of total body weight to blunt that sympathetic response. Usually 50 to 100 mics is, I say it's total body weight, usually no matter what, it's 50 to 100 mics. Now if you have a little old grandma, you're probably gonna give like 25 to 50 maybe, definitely not 100 to somebody super tiny. But most normal people, normal adult, no medical problems, gets 100 of fentanyl. And then lidocaine as well. So lidocaine kind of does 2 things. It will blunt that sympathetic response. It will also supposedly numb up the arm, numb up the vein where we're pushing propofol, because propofol burns. So I don't know the research on that. Some people use lidocaine, some people don't. However, most people definitely use fentanyl. You can also use like 10 milligrams of esmolol. Esmolol is very fast on and fast off. About 5 minutes is its half-life. 3 to 5 minutes, I believe, and it's metabolized by non-specific esterases in the red blood cell, and so it's very fast on, fast off, and it blunts that sympathetic response, namely the significant tachycardia that you get. So then we'll give our induction agent propofol, again, 1 to 2 per kilo. Most people get 200, unless you have, now obviously these are like healthy people. If you have aortic stenosis or you are very afterload dependent or preload dependent, then we're not going to be pushing sticks of propofol on you for those very reasons. So if you have severe aortic stenosis, we would opt for another option, or we would back the propofol way off and go very slow. And then we will give our neuromuscular blocker. Now this is where a little contradiction comes in. So in school we learn to give propofol bag, make sure you can adequately ventilate the patient, and then give your paralytic. However, in clinical practice, most people give propofol and then follow it up with rock or sucks. Most people nowadays give rock unless you're doing an RSI. And the reason we give rock is because we have Sugammadex available, and Sugammadex reverses rock or reverses non-depolarizers, rock more than anything, within like a minute. And so if you get in a difficult airway situation, you've given rock, rock lasts 25 to 35 minutes. You can give Sugammadex reverse very easily. And then you don't have the untoward side effects of succinylcholine. However, succinylcholine is going to onset very quickly, so 30 seconds, whereas rock is going to take about 2 minutes. And so push the rock, and then we start bagging the patient. And this is something that I didn't get in school either, is that most of my preceptors will turn the gas on. So we'll turn SIVO on after we've given propofol, after we've given rock, and we're bagging the patient, waiting for the paralytic to set in. We will turn the gas on to get them even deeper. And then after it's been adequately 2 minutes, we'll set the breathing circuit aside, turn the gas off, and then do direct laryngoscopy. One thing we're kind of going through SAMTIDE, but one thing I didn't mention, before you give your drugs, you want to adequately pre-oxygenate the patient, denitrogenate the patient. Same concept. So, there's more nitrogen in the air than anything, and so nitrogen is filling your lungs with a little bit of oxygen. So giving 100% FiO2 by a mask, breathing it in, you want to get the expired fraction of oxygen up to about 80% is what textbook you're looking for. Not all patients need pre-oxygenation, but we do pre-oxygenate every patient, at least to some degree. Maybe not to the end, maybe not until the end tidal O2 is greater than 80%, but we do pre-oxygenate everybody in some form or fashion. Okay, after we have done that, then we will intubate the patient. We're still going through SAMTIDE. I'm kind of walking through a little bit of both now. So the D was drugs. We're going back to SAMTIDE. And then E is everything else. So we have suction, airway, machine, monitors, tape, IV poles, drugs, and then everything else. And everything else would be like a peripheral nerve stimulator, an ultrasound, any miscellaneous items that you need. Another thing under the D for drugs is you get your induction drugs, but you also want to have your emergency drugs available. Now in clinical or in our simulation lab, we would draw up the emergency drugs. In actual practice, it's pretty rare to see people draw up emergency drugs. Some people will mix phenylephrine or neosynephrine and have that ready, but usually the emergency drugs aren't drawn up. They're just like in our medication cart. And so if there's some like hypotension that we have to deal with, the preceptor's like, hey, go mix up some neo or some ephedrine and then go give that. And we can talk about how to mix that. So phenylephrine, neosynephrine is a pure alpha-1 agonist, and so it's going to come 10 milligrams per ml, and the normal dose is 50 mics to a 200 mics push. And so how you would dilute that is this. You would take 1 cc, so 10 milligrams, and dilute it into a 100 cc bag for a final concentration of 100 mics per ml. That way you're giving 50 to 200 mics per push. Or you can take 0.1 milliliters and inject it into a 10 cc syringe for the final concentration of 100 mics per ml. Same math, just a different way to get there. Some people take the 100 cc bag. Sorry, my computer went off and it's like a little dim in here. Anyway, back to what I was saying. So some people take the 100 cc bags, do the 10 milligrams, and then you can carry that bag around all day and just draw your sticks of neo up from there. Ephedrine is 50 milligrams per ml, so you can take 1 cc, 50 milligrams into a 10 cc syringe, and then you'll have 5 milligrams per ml for 5 to 10 milligram pushes of ephedrine. And ephedrine is direct and indirect acting. It's going to increase norepinephrine release from the nerve terminals. So those are how those drugs work, and those are kind of our emergency drugs. There are other emergency drugs, so glycopyrrolate, atropine, sucks, all those things, but not super common. Usually the pressors, ephedrine, neosynephrine, are going to be the common things that you're just giving bumps of throughout the day. Common cases that I've seen, like I mentioned earlier, I've been in general surgery and robot, so I've seen a lot of cholecystectomy, appendectomy, Nissen fundoplication, colectomy, takedown of an ileostomy, reanastomosis of the bowel, lap hysterectomy, things like that. So a lot of hernia repairs as well. So for the past 2 weeks, I've mainly been just in the general surgery room. So after I get my SAM tide done, get everything set up, I will then go see the patient. I will go see whatever patient I'm seeing first that day. This is before my preceptor gets there. I'll go find out where the patient is, go see them in pre-op, do the pre-op, talk to the patient, get their history, do their exam, check their airway, and then by that time, the CRNA is usually showing up. We'll talk through the case, and then the patient will roll back, and we will get going. And so for the first few days, the CRNA was like right there beside me, like helping me through everything. And then now, like week 2, the CRNA is kind of like standing back, letting me do things. Obviously, if I'm doing something wrong, they're gonna like jump in. But usually they're like right in the midst of me, somewhere close during intubation, during induction and intubation. I have had the chance to do 27 cases so far. I have had 19 intubations, and I have gotten all 19 intubations. I had an unanticipated difficult airway situation. I had an older lady who was there for a general surgery. I was using a MAC 3. I looked with a MAC 3. I could see the epiglottis, but I couldn't see anything below it. I tried to reposition, look again, couldn't see, couldn't pass a bougie. And so my preceptor was like, well, let me take a look. So he took a look. He couldn't get it either. Made me feel a little bit better. And he was like, go get the glide scope. So somebody grabbed the glide scope, and then I was able to intubate with the glide scope. So that was my first kind of scenario where I was like, okay, I can't see. Could still mask the patient, could still bag. So he obviously came out, we were bagging the patient while we were waiting for the glide scope to come. And then we were able to intubate with the glide scope. So it wasn't that big of a deal in the end. But that's kind of how it has gone so far. Throughout the case, the CRNA is usually setting aside. I'm the one who's working the ventilator, working the gas. They're asking me questions, throwing some tips at me, asking scenarios. And then when it gets time for emergence and extubation, I will be the one to help wake the patient up. Usually the CRNA is right there beside me, like helping me, making sure I'm not missing anything. After we get the patient emerged and extubated, we're off to PACU. I will give a report to the PACU nurse, drop that patient off, go see my next patient, and then do it all over again. And so it's very much like busy for like 10 minutes, and then you're dead for like 2 hours. And then you're busy for like 10 minutes doing emergency and extubation, getting the patient to PACU, going to see your next patient, drawing up drugs for the next case. The next case comes back, same thing over and over, push the drugs, get the patient intubated, put them on the ventilator, get the gas on, and then you sit and you wait a couple hours. And it's very interesting though, because there have been some emergency type things that I've recognized intraoperatively with unstable vital signs, and I'm like, hey, we need to do something about that, treat that, get that taken care of. So for the easy cases, for the straightforward cases, it has been a good learning experience. I've had some interesting cases, and I've had a good chance to really like get my feet under me and realize like where I am, get my surroundings, try to get a routine down for how I'm seeing my patients, how I'm doing things, and that's been super helpful. So that's kind of what it looks like. Just superficial 30,000 foot overview of life as a CRNA student in the OR, what my cases have been like, and kind of what I've done. If you have questions, comment below. Let me know what your questions are. If you are an SRNA or a CRNA, comment below. Let me know what your tips are. It seems like there's something, a small something that I forget. Like there was one time I forgot the tape for the eyes, and so I'm like masking. I had just, given propofol, and I'm like, oh crap, my tape. So I had to like tear off some tape and tape the eyes really quick, and then go back to bagging. Or I forget like the 10cc syringe to blow up the ET tube cuff. So I'm like, hey, like grab me a 10cc syringe, we'll blow that up. So it's always like something small, and it's something different. And I think that just comes with time. Like this is brand new, obviously, like some of the skills I've done before, but being in that environment is all brand new. And so it's really just getting my feet under me, learning where I am, getting the same routine down time and time again. That's what's been helpful so far. Comment below if you have tips or tricks. I would love to hear them. Thank you for watching, and I'll see you next time.